So good evening and welcome to tonight's seminar. I'm Maura McQueen, the Executive Director of the Canadian Catholic Bioethics Institute. I teach here at the Faculty of Theology, colleague of Bill's and many of you in the room tonight. And tonight's seminar is co-sponsored by CCBI and the Sovereign Order of the Knights of Malta. We often do joint seminars, and I think it's very important that those continue. So welcome wherever you're actually from. And tonight, several people have actually asked if they could join via Skype, and I apologize, that's a little bit of the reason that we've started a little bit late, but not too much. I hope you don't mind that. One is Bishop Hageman from Yellowknife. There's Maria Kelly from the Catholic Medical Association in Calgary. John Heng from the International Association of Catholic Bioethicists, and he has many other titles as well. And we hope to do this more and more, but obviously I think it takes us a little while in terms of connections. It doesn't always flow just as well as we hope that it would. But the reason we're here is to hear Dr. Bill talk about this very topical subject, mental health, and especially in the context of the new legislation that's coming on assisted suicide and euthanasia. He calls it, "Where are we going?" It's a good question. And he's presenting highlights from two consensus statements that were developed during the International Association of Catholic Bioethicists' 7th International Colloquium in Montreal last summer. And Dr. Bill is going to be talking about issues of vulnerability, resilience, and wellness in medical and Christian understanding, and in light of these legislative proposals. And as most of you know, Dr. Bill is a family physician based at St. Mike's Family Health Team and Surrey Place Centre. He has a focused clinical practice in the primary care of adults with intellectual and developmental disabilities, or Autistic Spectrum Disorder, and the elderly. And he's the founding director of the Developmental Disabilities Primary Care Initiative and Program, and they promote the health and wellness of adults with IDD or ASD through developing and implementing clinical guidelines, resources, and training for primary care providers. And Bill completed, as well as his medical degree, a doctorate in philosophy with a focus in medical ethics. I think it was euthanasia, actually, very appropriate. He's the founding director of CCBI and also the International Association of Catholic Bioethicists, and he's also the chair of the Committee on Ethics of the College of Family Physicians of Canada. And just before I welcome him, I just want to say that we've decided to have a short break after Bill's talk, and if you have questions, would you please write them down? We'll pass around some paper, and I don't know that we'll be able to get through all of them, depending on the time, but we'll actually do our best. So please welcome Dr. Bill Sullivan.
Well, thank you very much, Moira. It's a delight to be here at St. Michael's, and I'm delighted to welcome many old friends who are here. And you can hear I'm a little vulnerable tonight, as we all are. I just got back from Geneva, and I had the delightful opportunity to have some meetings with some folks at the World Health Organization talking about person-centered integrated care. And that's where I picked up this problem, the World Health Organization. So what can you do? But I'm here just to talk to you about the results of a colloquium that was sponsored by the International Association of Catholic Bioethicists last summer. And I want to begin by acknowledging representatives of the Order of Malta in Canada who actually sponsored this event, which I think you will hear tonight some of the fruits of it, but I think it was very timely and important and fortunate that we were able to do this. This gives you a little bit of a sense of the folks who were there. People might recognize some of these faces. But we met for a whole week in a lovely place called the Marguerite Duville Center, just outside of Montreal. And so We had 70 people there for a week in a beautiful setting, which is very important for this sort of reflective work. People will recognize some of the folks in the picture. We had 70 participants from 17 countries, a mix of people with backgrounds in mental health and other areas of medicine, as well as philosophy, theology, bioethics, pastoral care, as well as people with compromised mental health and their family members. A very important contribution from those folks. This group is an international group of scholars in the Catholic tradition that we bring together. The group changes every time depending on the topic, but some of the folks are very prominent and have been very faithful to this process since our first one, which was here in Toronto in 2002. And people will notice Dan Solmacy was part of that. We had people like Francois Primo from Laval. He's a psychiatrist and quite prominent in Quebec. You might recognize Jean Vanier, so we had him joined by a pre-recorded video, as well as Sheila Hollins, Baroness Sheila Hollins, who's from the United Kingdom. She's an intellectual and developmental disability psychiatrist, and she's also past president of the British Medical Association and British Psychiatric Association. And by the way, all these presentations are available for you to view. They've been edited and they're on our website. So I'd welcome that, as well as the papers that were produced during this event. And so what I'm going to do is really give you some few highlights of, I think, important points of consensus that came out of this process that I think reframe how we think about what everybody's talking about these days. So these are the two consensus statements. The first one is on the value of palliative care, guidelines for healthcare facilities and individual providers facing permissive laws on physician assistance in suicide and euthanasia. And the second one is on promoting mental health towards a shared medical and Christian ethical framework. And as I mentioned, these are available online if you go to the IACB.ca website. Just to give you a sense of the usefulness of this process, and I think also the uniqueness, I've got a binder here of reports that have been produced by government committees and so on just in the last 6 months, and it's a huge amount of work. But I would contend that they did not do it in a rigorous method that we did, which involves getting to the heart of what's called the dialectic that's at the basis of this debate, and then working out the implications once you take a stance on that. And so this just gives you a little bit of a sense of the fruits, some fruits from this process. So one is, as a chair of a task force of the Canadian College of Family Physicians, we produced this guide for reflection on ethical issues concerning assisted suicide and voluntary euthanasia, which is meant to be educational and neutral, but I think articulated and unpacked and framed the ethical issues in a way that many people have told us is better than they've seen happening elsewhere. I also had the opportunity to contribute to the parliamentary joint special committee that was receiving input on the legislation based on some of this thinking. Another example there is a visit that made to the Javeriana University in Bogota and speaking with their ethicists. They're struggling with the same issues in a very Catholic country and context. Bishop Samard is pictured there shaking Pope Francis's hand. He's also a member of the Pontifical Academy for Life, and we were recently in Rome, and he shared with the committee Canada's experience. He was very much a part of this colloquium. And then just a couple other examples of people who were involved. Yarrow Katolik, that some of you know from the Northern School of Medicine, very, very much involved in the process and using it as a basis for teaching. Michelle O'Rourke, which some of you may know, also very much involved. And the whole point is that they go out and kind of continue the communication. So I thought I would just begin by highlighting a few points. It's only 5 points on this first consensus statement. This consensus statement is actually not that long. It's deliberately only 2 pages long, but it packs a lot of important points in it. And I think the first point that's made, and this is a quotation from the paper, a change in the law to permit assistance in suicide and/or euthanasia does not change the accumulated moral wisdom of a community. And so this distinction between the law and morality, and the importance of continuing to communicate clearly and with reasonable arguments the basis of opposition to assisted suicide and euthanasia for Catholics, communicate this to Catholics as well as others. And I just wanted to also mention, in light of kind of this important idea of continuing to communicate, these resources are available to everyone to use as a basis to aid their efforts to communicate to their own audiences. And in fact, that's the whole spirit of these colloquia, that everybody that is involved, they're kind of leaders in their own countries, and take what's useful from this sort of consensus process to help communicate in their own contexts. This is another sort of, I call it an ethical framing that might be a little bit novel. That the issue of protecting the ethos of Catholic and other healthcare facilities ought to be done in terms of the right of persons to access to supportive care environments from which assistance in suicide and euthanasia are excluded. What is a bit unique about that is it's really people first language. These are the people we're serving. It's not about doctors, it's not about institutions, it's not about maintaining a rigid concept of what we're all about. It's about providing an environment where people can be cared for in a certain way. The statement goes on to address the importance of that all healthcare facilities and schools should address attitudes, values, and behaviors in healthcare which give rise to support for assisted suicide and euthanasia. And I've just got some examples there of some thinkers that you might be familiar with. Atul Gawande and his book on being mortal, and kind of this notion of medical brinkmanship, of kind of overly medicalizing death, for instance, and the effect that has on people. He also talks about the fact that we have built a whole system of caring for the elderly that's not based on the needs of the elderly. It's based on the needs of institutions. So this is institution-centered care. And I think one of the things that he highlights is the modern plague of the elderly. People have read this book. He talks about boredom, loneliness, and helplessness. And so if those are our modern plagues, what are we doing? I've also got Dan Solmacy's book, The Healer's Calling, where he reminds us of the essential importance of spirituality in healthcare and the whole vocation of the healer. And then there's I think a seminal paper from the Emmanuels that people may know about that talks about different models of the doctor-patient relationship and highlighting the models, the two sort of dominant models. The one that's been rejected is paternalism. The one that's been embraced is called, they call it the informative or consumer model. And that, with that model, there's a whole bunch of assumptions about what it means, what the role of the physician is, especially as concerns value judgments, and what autonomy means. So each of these models shapes the whole discussion. And I think that what we're hearing is the consumer model of healthcare. That's the model that's embraced, and nobody seems to be questioning whether that's adequate. So this very brief statement is calling Catholic healthcare facilities to be leaders in offering excellent holistic healthcare, including palliative care, throughout illness, aging, and at the end of life. And this would be to offer alternatives to assisted suicide and euthanasia, and to encourage our healthcare facilities and communities not to depend entirely on the government to take the lead on what it means to provide holistic and people-centered care. And this is actually the last thing I'll highlight, which might be a little bit controversial. But there was a consensus that where there are laws permitting physician assistance in suicide and or euthanasia, it is morally permissible and may be prudent in order to protect vulnerable people for providers and facilities to work with legislators, regulators, and educators to limit the scope of these practices and ensure transparency and oversight. And so that's part of what I would see as my sort of mission, to kind of be involved in all these committee discussions, even though these discussions are actually very difficult. So I'll leave that first consensus statement and move to, again, highlight just 5 points from the second, which is the longer consensus statement, and then move to kind of reflect on how the two are connected. So the statement is on the value of promoting mental health, and it kind of encourages people to recognize the crucial role of mental health disorders, or what we call in the paper compromised mental health, that psychoaffective and spiritual distress, invulnerability of patients, and requests for assistance in suicide are all often connected. To adopt a consistent approach to assessment and intervention of all suicidal behavior in healthcare, and to promote mental and spiritual wellness throughout life, not just at the end of life. And I think what might be a bit novel is to identify the act of a request for assistance and suicide, suicide or euthanasia as a suicidal behavior, and think of it as such. Very few people talk about it that way. So the statement goes on to attempt to articulate and promote a shared medical and Christian understanding of mental health and wellness, and an ethical framework for just thinking about these things. So this is another quotation from the statement. Mental health and wellness should be understood holistically to take into account interactions among the biological, psychoaffective, social, and spiritual aspects of human beings, the social and environmental determinants of health, and the need of human beings to find meaning and value in their lives. So this is actually the cultural dimension of trying to find meaning. The statement urges that mental health is as important as physical health to human wellness. There's an adage that comes from the United Kingdom that says, there is no health without mental health. There should be better integration of mental health care with other aspects of health care, particularly physical health care. And mental health should be as vigorously supported and promoted as physical health. So the statement goes on to then link what we're talking about in terms of health with spiritual wellness. That spiritual wellness is related to both mental and physical wellness and resilience. Spiritual care should be part of healthcare. Christians should be more aware of the importance of mental health issues in spiritual and pastoral care. So thinking about issues of loss and trauma and adjustment as both spiritual issues, but also have important mental health sequelae. Christian communities and healthcare organizations should contribute to excellent mental health and spiritual care and oppose stigma and exclusion of people with compromised mental health. And I recall this whole idea of integration of kind of the physical health care, the spiritual care, religious practices, the importance of connecting with the environment, some of the things we were talking about. The Order of Malta has a famous hospital in Malta that I visited recently. It's a 16th century architectural wonder at the time. Actually, it's the longest freestanding ceiling in all of Europe at the time. But every patient was able to have privacy, access to a beautiful courtyard with fruit trees and places to walk, and everyone could see from wherever they were the altar and could participate in religious services. So back then they had it all integrated, it would seem, in a way that you will not find in our hospitals. Another important notion that is used in this statement is this notion of moral agency. And here we're referring to respect for moral agency in mental health care should include promoting ethical deliberation and should be considered together with other ethical principles such as solidarity. So this notion of moral agency and of helping people to exercise and develop their moral agency is another way of speaking about autonomy. So it is a developmental skill that's lifelong and something from which we need the help of a community. And so there's this sense of another model of the doctor-patient relationship that's called deliberative, where in fact this is part of the role of a healthcare provider, is to help ensure that one is promoting authentic moral agency. And there's another issue of justice here. A just distribution of resources in healthcare and in society should address disparities between resources available for mental health care and the rest of health care, as well as barriers and disparities that impede access to mental health interventions for those most in need of care. And people may be aware of the huge discrepancy in health care between what is allocated to physical health care as compared to mental health. And so it's kind of de facto how we in society value these two aspects of our care. So those are some highlights from the two statements. And I guess I'll sort of just conclude with some reflections on connecting the two. So we deliberately separated this longer consensus statement on promoting mental health care from the other statement that had to do with the more specific issue of the value of palliative care and of promoting good palliative care and opposing, or at least giving some guidance to individual healthcare providers and to institutions who are in a legislative context where physician-assisted suicide and euthanasia are permitted, and that's the very context that Canada finds itself in. One point that is raised a lot is this notion of intolerable suffering. And just to point out that this is actually a multi-dimensional notion, that it involves physical distress, but in fact, that's the minority of cases, and at least when you look at people that are requesting assistance in suicide. Because it also has dimensions that are psychoaffective, distress that relates to loss of control. It's especially an issue for those with issues of attachment, and so we heard from psychologists about the importance of early attachment, people with a very strong need for independence. There's the issue of depression, that about 25% of people that are requesting assistance in suicide are likely to have undiagnosed depression. There's issues related to personality types and anxiety, transient responses to stresses, often with losses. There's the issue of affective disability, such as people with what used to be called a form of autism spectrum disorder called Asperger, and the famous cases of such individuals receiving assistance in suicide in Oregon and Belgium. There's distress that has a social component, and it has to do with isolation, senses of being a burden on others. And then there's a spiritual existential distress that has to do with hopelessness, a sense of just existing, or lingering without meaning or value. So it turns out that only a minority of requests for assistance in suicide or euthanasia in seriously ill and or dying persons are for reasons solely of unmanageable pain, dyspnea, or other somatic symptoms. And I think that there is this idea of how well equipped are we in modern healthcare to deal appropriately with such issues and concerns. And there's this issue of our ability to make good diagnostic formulations and management and manage well mental health issues. The further issue of how poorly resourced mental health care is, even in palliative care. That spirituality and religion are often overlooked or dismissed as unimportant contributors to overall health and wellness. Negative attitudes that exist toward aging and disability. Suffering and dying remain very much medicalized, often inappropriately. And the need for mental health promotion, not just at the end of life, but throughout life, and to see it as this importance of prevention. Talking about kind of people suffering and dying, one wonders about what we do in obstetrics with midwives, some wise person to help guide people through this, which is often not very medicalized. And if something like that is not needed in this area as well. And I think what we also how these two issues of mental health and assistance in suicide relate is, what does this do to a coherent approach to suicide prevention and healthcare? So one of the a common term that's being used is rational suicide. And there was a very helpful contribution by Baroness Sheila Hollins about the idealism that's behind a lot of statements that are being made about this, that it reflects what she calls strong-minded people who are always in control in their lives, who have thought carefully about dying, know exactly what they want and don't want. And that's very few of us. And yet that's the presumption that's behind rational suicide. And then there's this issue of a transient wishes to die, which are not suicidal behaviors. This is basically kind of something that many people think about when they're undergoing difficult times. And I guess this whole issue of undiagnosed and unmanaged mental health issues that in fact compromise this notion of moral agency and autonomy. And speaking to a psychiatrist recently about this, who's a leader in Germany on the largest suicide prevention intervention in the world, he said I asked him, do you think that the average family physician is able to diagnose depression in somebody who's asking for help to end their life? And he said no. He said most people that want to end their life, they will look up what are the signs of depression and they won't tell you that they have them, right? Because that's how you diagnose. People have to be open to revealing how they're doing. And there's this notion that these assessments are simple. Two family doctors can, each give an opinion and come to a conclusion. But we're talking about a diagnostic formulation. People come to you asking for a treatment. The issue is, what's the diagnosis, right? And it would seem like it doesn't matter as long as it's severe. But in fact, a diagnostic formulation is a complex issue. And that's where to really do a comprehensive formulation and understanding, it has to be multidimensional, as I've been saying, physical, psychoaffective, social, and spiritual, to sort of, and in the context of losses, traumas, relationships, and so on. So it's not such a simple thing. And it is interesting to note, and I've got a book of studies that were referred to during our colloquium, that there is no difference in the social, psychoaffective, and spiritual predictive factors for unassisted versus assisted suicide. In other words, this category of rational suicide versus other suicides, it's difficult to draw this sharp line that's presumed. The same factors associated with decreased risk of suicide correlate with lower rates of requests for assistance in suicide. So in other words, you address the same factors for anyone, and it will also reduce requests for suicide. Yet there seems to be a greater acceptability of assisted suicide or euthanasia among the public and healthcare professionals when the person has a serious or terminal illness. And I'm recalling a notion that the Pope mentions and is picked up by Cardinal Collins in his letter about this notion that if you can't fix something, then it's discardable. And that's how we can treat people. So this suggests negative attitudes, both in society and healthcare, toward people that are in these stages of life, aging, disability, life with a serious or terminal illness. And there are all kinds of implications of those attitudes that we can talk about a bit more maybe during the question and answer session. But I just want to sort of flag one thing that was quite a shock to me. I was part of a study that was funded by the Canadian Institutes for Healthcare, CIHR, And it was looking at the issue of suicide and euthanasia around the world, multilingual, a very comprehensive search. And they would have categories of articles that were retrieved, requests for suicide and issues about, the individual requesting and so on. And there would be thousands of articles that were retrieved under each of these categories. And then there was one category, effects on family and loved ones. 0. They could not find one research study that looked at effects on family and loved ones. And that's a huge issue, because it's quite hard to understand how that could happen. But we are so individualistic in our outlook, I suppose, that family and loved ones become, not really factors worthy of study. I don't know. But in fact, this has a huge effect on family and loved ones. So this is the question, where to go from here? I'll be very brief. I guess the first is get involved. And this, I think the emphasis is to continue to communicate the ethical basis for opposition to assisted suicide and euthanasia, as well as the value of mental health care and comprehensive and continuous palliative care. In other words, palliative care is not just when people are dying, and palliative care is not just about somatic symptoms, and that it needs to be much more comprehensive and continuous. Press for legislative amendments, and these are two suggestions, amendments that I think are important and are possible to succeed. And that is the right of persons in need of health care to safe havens. And I ask my patients about this, and they say, I don't want to be in a hospital where, the person next door is, in the next bed is going to disappear overnight from euthanasia. But right now, it's not clear that there will be any such places. The second is adequate mental health and vulnerability assessments and appropriate therapeutic interventions for those. We know they work. And I think that a message that Sheila Hollins makes that I thought was very helpful is that even if you're dying, it's not normal to be depressed, right? A lot of people think, well, of course you're depressed. That's normal. You're dying. No, it's not. It's a treatable illness. And it happens at any stage of life, including when you're, facing serious illness. And so these things need to be assessed properly with proper and proactive therapeutic interventions that we know work. Help to shape policies and education of physicians, nurses, and pharmacists. So just an example of this, I'm on a committee that is preparing the education for people in Canada who will be need to be up to speed physicians on these issues. And they're importing a leading proponent of euthanasia from the Netherlands to be kind of the key person who's educating us. Well, that's fine. That's a perspective. But it shouldn't be the only perspective, and it will be the only perspective if other people don't step up. And it's not just physicians. It's also nurses, and it's also pharmacists. These are, they're already talking about developing education in the residency programs in the medical school, right? And so there better be a wholesome discussion of the issues. And offer alternatives now. Catholic healthcare facilities should lead in providing excellent education and alternatives to assisted suicide and euthanasia. This means excellent health, mental health care. That they should be the leaders in spiritual care, helping people to find meaning in human vulnerability and limitation. If people have not read the article by Jean Vanier, March the 1st, 2016 in the Globe and Mail on the fact that we are all fragile. I would recommend you do that, because this is what it means to be human. Comprehensive palliative care throughout illnesses, and most people these days are carrying multiple illnesses for many years, and they need to have good palliative care even while those illnesses are being managed. Care of the elderly and end-of-life care that is person and people-centered and addresses these modern plagues: loneliness, helplessness, and boredom. What do we have to do about those things that actually are killers for people? Being lonely is toxic to the human soul. Care that values the lives and gifts of people, even those, and especially those, who are struggling with serious illnesses and disabilities. And finally, to be proactive. Promote all aspects of wellness, including mental and spiritual wellness, for enhancing resilience in the face of human limitations. Thank you very much. Perhaps before I forget, I did have a question that was asked from our viewers on Skype, one of our viewers, and it was about this notion that it's not normal to be depressed even when you're dying, and some of the implications of that, and how that might be a novel message, and we have some psychiatrists here that can tell us. But also how we can work with people, I think, in a positive way to make this time of life as meaningful as possible. And I guess, again, this was something that Sheila Hollins talks about. She's a psychiatrist. And there's actually a video of hers which is very excellent. And it's actually, she has a little mnemonic, it's called Grace, that she only had a small amount of time to talk to young people, a very big audience of young people, about some good mental health practices. And I won't get into it all, but you can see it on the IACB website. But I guess the idea is that these are sort of habits that should be lifelong, not just at the end of life. And that this is actually what helps people to be resilient when they're faced with the difficulties that come at different times of life. I think another very positive story she had was a colleague of hers who was actually a campaigner in the UK for euthanasia, and when he actually developed, I think it was ALS, and did not. Met with her soon before he died of natural causes and talked to her about how important that time was for him. So kind of a conversion story, the importance of closure of relationships, of having time to connect with people and so on, and to kind of see this time as a very important time of life. I think actually people that die suddenly don't get that opportunity, and so that's part of the tragedy, that there's no opportunity for such closure. And it may be the case that in this new environment, it will be more the exception that people have that time to prepare. That in fact the attitude will be, what's the point? Let's get it over with, be efficient. And so maybe a message there is that we should all be prepared now. And kind of be doing that kind of work.
Okay, two questions here. First one, do you have any comment on the polls which suggest that a majority of Catholics agree with medical assistance in dying?
Yes, it's. I think one comment is just about polls in general, and this is actually the comment that the head of the World Medical Association made in this conference that I was just at. He says, because this is actually a scientific tool to get a sense of, fairly quickly what a large group of people think. And his view was, it all depends on how you ask the question. And I think we have, in Canada, given a lot of credence to this sort of information that is very easily manipulated by the way the issue is framed. And I would probably answer positively in the way most Catholics do, if it's worded like in the extreme ways that some of these questions are worded. So, so we should, this is kind of an issue of sophistication when it comes to collecting information like this, and being critical of methodology. So yeah, that's my comment. But I think it may be that a lot of people, and even Catholics, need education on these issues, and and just to talk about these issues. I think we're all in the, we're all affected by a culture that is kind of death denying and glorifies youth and independence and, sorry?
Autonomy.
And autonomy, yeah. And so that's exactly the point that John Vanier makes in his note, in his letter. So we have to recognize that will affect us, our attitudes as well. And it is quite countercultural to actually say that, it's actually part of being human to be interdependent and to be able to accept that and to live my life to the end in need of care of others, and that's okay.
May I ask, this raises a point I have been concerned about for quite a while. It's language.
Yes.
We have medically assisted dying,
Yes.
don't we?
Yes.
That's what palliative care is about.
Yes.
And if you allow this particular issue to overtake that language, we have to begin to distinguish
Yes.
between what we're doing and assisted suicide.
Exactly.
There
Yeah.
is a huge gulf.
Yeah. So I guess obfuscation comes to mind. It strikes me that it is a communication tactic to actually put this positively.
I agree.
And to sort of, and it also allows the argument that this is part of the continuum of end-of-life care. And so medical aid in dying, I mean, who's going to be opposed to that? Yeah, so language is very important. It's part of communication. And the other distinction that has been lost is between, on the grounds of autonomy, providing assistance to somebody who wants to kill themselves, and euthanasia. So people may not know this, that most people that request assistance can do it themselves. But in the Netherlands, it's like 9 out of 10 people could do it themselves. But in fact, 9 out of 10 people receive euthanasia, not assistance. And so where's the autonomy?
Yeah.
But that distinction and actually the moral and psychological implications for the healer to be involved in that is actually lost by not making that distinction. So if you look at the law and so on, they're both conflated as if they're the same thing. And the assumption is that this is a medical act and it is a therapeutic act. It's normal.
Yes.
Well, even in the places that allow it, don't call it normal medical practice. There's no other thing we do to relieve suffering by killing the patient. Oh.
Thanks, Bill. It was a good talk. A couple of comments. One is when we normalize things like this, we end up sort of changing the moral sort of fabric of our community.
Mm-hmm.
And one of the things that you mentioned in there is how even when it seems to be the wrong thing to do, we need to get involved in creating policy. And despite the fact that we don't want it to happen, it is now legal in Canada. We can't change that. All we can really do is help structure the new legislation to protect the vulnerable, to protect people who don't want to get involved in it, physicians, nurses, social workers, all that sort of stuff. But right now, it seems that we're going to have the most liberal law in the whole world, and if nobody puts up any sort of comment on it, it'll end up that way. I think when I read the newspapers, it's all about how we haven't gone far enough.
Yes.
Right? And if nobody talks about how we need to structure it so that we're not impinging on the rights of people in terms of the ones who don't want to have medically assisted dying, if you want to call it that. Really, it is euthanasia in most cases.
So I guess just to repeat the question, it sounds like you think it is a good idea to get involved, even though we're opposing. So one of the comments by an ethicist who was part of this colloquium from Australia, Bernadette Tobin, and she just said this as sort of a reflection of her objection to this as a public policy is it is, she said, unregulatable. And you will see that any kind of distinction that's made is, here today, gone tomorrow. And it's this genie out of the box. And how do you then control it? And unfortunately, that's the way we've gone. And, we can do our best to try to set limits, but if she's right, it is, very difficult. And so, I've got some quotations from studies that talk about, reasons becoming tired of life. I'm old, things like this. So yeah, it's a concern. But yeah, to be involved in, actually this is a very important time when the legislation is being debated at this level for people to get involved. I think one very important term that's come up that's I think allowed a way of speaking about this protection of people is vulnerability, and to recognize that there are a lot of people who are vulnerable. And so a group, it's actually through the Community Living Associations of Canada, have promulgated something called the Vulnerability Standard. And it just flags 5 things to think about when people may be requesting help to die. And so that term vulnerability is even in the draft legislation. And so it was only because people got involved that gives people some language to think about this balance that the Supreme Court said was the job of the legislators.
There are so many questions which are good, and just a little aside on that, because I'm not really supposed to be asking questions, but there are so many ways of being involved. All of us have been talking about this for months, and the current one with conscience and healthcare that Cardinal Collins has endorsed, and CCBI, and 2 Catholic physicians groups, and COLF, the Catholic Organization for Life and Family, the bishops group, are doing exactly that, demanding palliative care, demanding that conscience rights be protected, and not actually, again, working towards policy with government, but demanding things of government. So there's many ways of dealing with the whole issue. This question does revolve around this a little bit. Do you think our primary strategy as Catholics, when advocating in the public square on the issue of euthanasia and assisted suicide, should be 1, arguing against the permissibility, legality of these practices for all people, that is, arguing that these practices should not take place in any hospitals, or 2, advocating for the freedom of specifically Catholic or Christian institutions to uphold their own confessional ethos and environment and to reject these practices?
Well, that's a good one. I think you can argue both. You won't win on the first one. The law is against us. And one of my friends and colleagues who's on the Pontifical Academy was involved as a legal scholar on this whole Supreme Court decision and at the trial level, John Keon. And he said to me, the law is not on your side, and that makes a huge difference. So to kind of grieve it, but accept it, we've lost. But the second point was about, and that's kind of what I was advocating, can we press for some safe havens in the Canadian landscape? And I think it's more than just Catholics that want that. And even people with no faith. You know, there was some very good, recently some letters in the Globe by a Toronto physician who has no faith but would join us on this one. So yeah, so I think part of it is actually this is a question of prudence, and but I think that the strong message was, from this group at least, was get involved, even though it's in many ways a very sad situation. But still, it's worth being involved. And I know many people that are very involved in education and so on that really don't agree with this at all. And yet, the mere fact of them being present changes the conversation, because it's quite shocking to me how poorly understood the Catholic position is by very educated ethicists. And that they have no clue of the whole tradition of virtue ethics and so on. It's why there should be any conscience concerns and so on. So it is important that people be at these discussions at this time.
So how important is it to frame political opposition from a secular standpoint? Does it necessarily carry more credibility to hide the author's spiritual motivation?
That's a tricky one. But I'm inspired by Margaret Somerville's sort of ongoing advocacy on this particular issue, and she never does it from a faith perspective. And I think it's, for her, that's just a matter of prudence, that in the current climate, like in healthcare, that the spiritual perspective is not valued. So that's why, other types of arguments that would sound reasonable to your hearers are what we've tried to put forward in these consensus statements. And so, and yet not shy away from the deeper spiritual reasons for these positions as well. But I think it actually is a matter of prudence and who your audience is.
And this one, more specifically medical, is palliative care capable of managing all cases of pain?
Well, first of all, if we're talking about reasons for people wanting to end their life, according to the research I've been reading, strictly somatic pain as a reason for intolerable suffering that would lead one to want to end their life is actually quite small. That the number of people is quite small. And I think that palliative care, its last resort is palliative sedation. And one of our consensus statements was on palliative sedation and was advocating that it has an appropriate and ethically justified use in these extreme cases. And yet the people that are actually writing and the proponents of euthanasia call that controversial. What's so controversial? And instead they think euthanasia is not controversial. So it's a bit strange. But anyway, I think the first point is that there are types of pain that are somatic that will lead people to want to end their lives. But if it's just physical pain, which I think is not that common, just physical pain, there are tools to manage that. Physicians never like to say everyone, but everyone can be sedated until it's tolerable. That's one point. But the second point, and I think that this is more controversial, but the opinion of this leading psychiatrist from Germany is that we think that people are asking for assistance with suicide because they have severe intolerable suffering, and suffering is broader than physical pain. But in fact, he said, if you, the largest study in the world from the UK looking at suicidal behaviors, there was no increased risk of people wanting to kill themselves because of these end-of-life symptoms. So this notion that people are wanting to kill themselves because life has become intolerable from physical pain and end of life, it misses the point. We're talking about suicidal behavior, most of which has nothing to do with any physical illness. And this is actually a huge problem worldwide. I was just, I mentioned I was in Switzerland, a priest friend who works there, who's on a team that goes to comfort families after a suicide, and in the last month there were 11 suicides, and these are shopkeepers, and they're not taking drugs, right? They're jumping in front of trains, they're shooting themselves, and so on. So that's the issue, and it's a huge cultural issue because of loss of meaning. And I would say it's a complicated phenomenon, but for this German psychiatrist, the link between depression and suicidal behavior has to be made. So whenever anybody talks about somebody asking to be made dead, think depression. And I think that's a message that I haven't been hearing too much. And we really need our psychiatrists to step up and educate the public about these issues.
This is a psychiatrically based question. So the Canadian Psychiatric Association has asked for a delay of 1 year before implementing physician-assisted dying for persons where mental illness is the sole underlying medical condition. Would you care to comment further?
Yeah. Well, I'm glad they've asked for a delay. It's probably not going far enough, but you will note that what the language now is sole reason is mental health. But what about the majority of cases, I would say, which the sole reason of physical, somatic suffering is very rare. But I guess the other thing is that most people are asking to end their lives will have some element of, let's just call it distress that is undifferentiated. And so this gets back to the complexity of the beings that we are, physical, social, psychological. We've got the traumas, we've got the adjustments, we've got the attachment, we've got epigenetics, and we've got spirituality. And that's what is talked about when you're talking about intolerable suffering. And how do you piece out the mental health stuff? So, if you had one person that's clearly this is just mental health and it's none of these other things, well, that would be, take a year to think about that, but that's not going to be very common. It will be this conflation. And the only other comment I would make is the way that we are thinking about these things is a certain formalism of what's called a logic model, or I guess, for medical protocols, you do this and then you do that. And ethics doesn't fit into that. And so they're going to take a year to say, well, we check and see that they're capable and that they meet these and these criteria, check them off, and yes or no. And it sort of is a way of thinking about ethical decision making that actually takes ethics out of it. And so the person that comes from a virtue ethics point of view would say, well, what are you doing? Where's the healing virtue in this? And that, because it won't fit into those formulas. So when it comes to the, helping come up with these logic models, I refuse to get involved because I think that they are inherently, the bigger ethical question just gets sidetracked. And that the Psychiatric Association can take a year thinking about this model, but they may never ask the ethical questions.
Well, hopefully in the time that they're waiting, they could develop some of those ethical questions.
Yeah.
At least they're asked, they say clearly, we have no guidelines, I'm a psychiatrist, we have no guidelines on how to determine whether somebody who's asking for suicide is not sick.
Yes.
And we should treat the sickness.
Yeah.
We have no guidelines. They want a year to develop guidelines. Let me tell you, in mental health, we know the cause of nothing. We don't know what causes schizophrenia. We don't know what causes depression. We don't know what causes bipolar disorder. And even the attachment theory, it's about one of about 108 theories we counted the last time about how to explain human behavior. But what psychiatrists do know is how to treat symptoms.
Yeah.
Okay? We do definitely know that. But as far as treating causes, we don't.
Okay. Thank you.
I think the other issue with that is that, my understanding was that they were asking for a year for a person who asked for suicide.
Oh, yeah.
I'm not sure that that's the case or not, but.
No, I think to develop.
Is it just to develop?
Develop the
It's to
protocol.
develop guidelines, which the good part is, I'm glad they're asking for a delay. The bad part is they're actually looking for guidelines on how to let somebody who wants suicide from a mental point of view, to let them commit suicide.
Yeah.
That's totally anathema to a psychiatrist.
And the other issue here is this waiting interval, because in the current legislation, 2 weeks, and if you're trying to assess a psychiatric issue, 2 weeks is nothing. So anyway, if the mental health issues are key to all these requests, all these suicidal behaviors, to unpacking them, then 2 weeks is just, no psychiatrist would think that's sufficient. And also, there is no requirement of anyone with expertise in, assessing suicidal behavior to be involved. Phil?
Yeah, I'm speaking more of the legal part. It's fascinating the rush we moved through this to get to where we are in the context of, for example, in 2013, 2014, the Irish Supreme Court took a look at the exact same studies that were in front of Justice Smith in DC in the original Carter decision. It came to the exact opposite conclusion about what dangers lay ahead. I'm also struck that, the UK courts, the European courts have all said these are matters for legislation. I'm commenting about, in the context of this, your colleague, Dr. Wheeler, who treats my brother who's got Down syndrome, 63 years old, and I said, I'm involved in trying to do the advocacy on conscience rights in this issue. And it's interesting from a guy who's a great doctor, a lovely man. He said, well, very few people will actually take advantage of this. And I had to say, well, no, the numbers suggest in Belgium and Netherlands it's between 4 and 5% of all deaths, i.e. 1 out of every 22 people who are dying, who are reported, are taking this route using doctor's assistance.
So it becomes normal.
It becomes, yeah, and the notion is even the doctors who should otherwise be aware, who are otherwise opposed, don't recognize what's coming. I mean, why do we think Canada is going to be immune from what the other world experiences are? Is unfathomable. Well, back to comments. One of the thoughts, you just talked about the 15-day waiting period in the current bill. It's really 2 questions about the current bill. I've been thinking and speaking to others about, well, why don't we use those 15 days to provide mandatory palliative care for those 2 weeks? In other words, if we believe what it means, that may have an impact for that person to alleviate, to provide some different new normal that may change minds. The second proposition is, having seen the bill, having seen the immunity being provided to third parties, which is nowhere near what the Supreme Court mandated, And although it's not as expansive what the Joint Committee proposed, I'm coming to the view that we should just oppose C-14 outright. The reality of the Carter regime post-June 6th provides a defense for doctors who participate in assisted death. What the bill is doing is expanding that to nurse practitioners, healthcare providers,
Right.
third parties who are not even physicians or medical workers. And my view is to say, well, maybe we're better off just saying what the Supreme Court has said, we're striking down Section 241A of the Criminal Code. And I don't know if people have actually thought through that. I don't know if I've thought through that enough to say that in effect, we all recognize, like you say, here today, gone tomorrow, that the new regulatory regime is just going to be the next year's court challenge.
Yeah.
My own thinking is, you know, Supreme Court, you brought this in, you buy it. You take on the responsibility for what is the new normal.
Yeah, it's a good question. You began with the comment about interpretation of studies by kind of the folks in the legal world. So one group in Ireland looked at the same studies and drew the opposite conclusion. And I think to me, one lesson from this is that that there is a need on these complex questions for genuine interdisciplinary collaboration, where you get the relevant expertise coming together with adequate time to kind of share perspectives and unpack and critique and so on. And that doesn't happen normally. And so I think getting back to this whole methodology of bringing together a group of people for a week to kind of think through these are pretty heavy topics. Mental health is, I think we realized, is a huge topic, and we were just scratching the surface. But we did realize that the Catholic world has not gone very deeply on these issues yet, and yet they're hugely important to people that are interested in promoting and helping people on the spiritual journey of life. But I guess the point is to have the wherewithal to bring together people with the different skills to unpack what's been written by others, what others are saying, but then together to say, well, here's what we think, and to spell out the implications. So this was an example of doing that. And it's I think much more robust than this judge trying to discern and make sense of very sophisticated publications with methodologies that unless you've got a pretty good team, it's very hard to critically assess the evidence that's being provided. And so it's sort of the modern problem. I think we've been sort of, I think the other thing is that the Supreme Court is not making claiming to make a moral judgment, but they are dealing with a moral issue. And so they have to recognize that there is a moral dimension and they need that expertise. So anyway, I guess it's, in a sense, what I'm saying is that this is a current example that has, I think, pretty important implications, but to have a group of people that are being supported to think these things through carefully, not under some unrealistic timeline, but well in advance, and to kind of do this sort of thing where it was made available in writing and people can see the speakers, the recording of these presentations and so on. I think it's quite a unique thing to offer, and I just hope people will find it helpful and will kind of be confident to kind of continue the communication, because none of us, we all feel insecure on these complex issues because most of us have a certain range of expertise, but on these questions, you need a much broader range of expertise of people that can really communicate with one another and kind of come to consensus on some challenging issue. So that's kind of what we try to do, and I hope you find it helpful.
Bill, just one last comment, and then if you don't mind, and then we better stop. Ron, you were wanting to make a
Yes,
comment, I think?
yes.
Yeah.
Do you want to come up maybe,
Maybe.
if you don't mind?
I could. I'm not going to give a talk or
Oh, it's
anything.
okay.
We'll see.
First, I'd like to ask you a question, and that is, were you on the consultation board when they were talking about what should be in the act? The
The
group, the joint.
Yes, no, but I just submitted I was one of maybe 62
Okay.
that were witnesses,
Okay.
but it was a written submission.
Okay. That was the first question. My questions are, it's more comment than question, but I think a question will come out of it. First, I would like to say that we keep talking about Catholic all the time. To me, this is not a Catholic issue at all. This is a values issue.
Yes.
And what are our values? And the more we talk Catholic, the more we're going to be ignored. So we really have to talk about values. And the value, as I see this, is that the culture of life. That's what this is all about. From birth, from conception to death, we have to value the culture. I think that's the message. And there are tons of people who are not Catholic who support this idea. So that was one thing I was going to say, that otherwise we get absolutely nowhere with the whole thing. The second thing is that, excuse me, it's inevitable that this is going to take place. You know, it's there. It's going to be written. So what I think we should try and do, and what I'm trying to do, is to do something. If we can change the details of some of the passages in the law, we have very little time. But you know, if we can do something on that. And one little thing, which today I was reading the Globe and Mail, and there was one article, I can't remember the name of this person. He talked about options. You're giving to people two options: euthanasia, or you're not giving them palliative care. That is the issue. You should be giving them the option of palliative care. It's you have to die or not. You know, it's that kind of thing. The more they stress that one of the options that people have to have is palliative care, we're going to see some action taken for palliative care. I mean, the Cardinal stated quite clearly, he says, less than 30% of people needing palliative care get it. So what about the 70%? I mean, something needs to be done about that. Now, of course, some of us are trying to do something about that, but the fact is, that should really be in the document. In other words, that should be a choice. We talk about people having their choices. It's not a choice given to people here. It's just forgotten. So those are the points I had to make actually. In other words, what action do we need to take? Because legislation, you know, we can talk about this forever. It's a very complex issue, and we all have different views. And you know, there's the legal, there's the medical, there's psychiatric. But we need to do something about it. And some of us just have to move forward and do these things. So that's all I had to say.
Good.
Thank you.
I think we've got enough questions.
Sure.
All right. So thank you for the questions. And I know some people submitted several questions, but I did ask one question from everybody's list. So I just want to thank Bill very much once again for coming along tonight to talk about the consensus statements, number one, and to raise the profile, if you like, again of people with intellectual disabilities. The mental health issues that we know over the years are the ones that are not really paid enough attention to. And then linking it with the current climate in terms of the coming legislation, and also in terms of what we can still do. We'll probably maybe do it in different ways, but all the time I'm talking to people in parishes, etc. I encourage them constantly to speak to their MPs. They still haven't voted, and so there's a possibility. It's very much a long shot. At the same time, even if the legislation is voted in, I think it's important for people to have their moral stance clarified and just expressed. And I think you've really helped us tonight by, you've covered many, many topics. All of them, I think, require other seminars in many ways, and I hope you'll come back and do some of them again, especially from the mental health perspective, which I do agree, especially, even if you shouldn't use the word Catholic too much, but from a Catholic and Christian perspective, I think we could have a different sense of how to be more involved in this, recognizing the really high percentage of people with mental health problems. The Pope always talks about destigmatizing people, and I think that mental health stigma is something that still persists. So we do have a pretty good encourager there. Just want to thank all of you for coming out again, and to Bill especially for helping us with this joint CCBI Order of Malta seminar. Thank you very much, Bill.
Thank you.